So the last group of drugs that we will discuss for heart failure include the aldosterone antagonist, also known as the mineralocorticoid receptor antagonist, also known as the potassium-sparing diuretics. So any of those terms are equally appropriate for this next group of drugs we're going to discuss. So understand that aldosterone has several roles in the pathophysiology of heart failure. And so this basically just kind of summarizes the different pathophysiological effects and the mechanism by which this occurs. And so understand that aldosterone is going to alter sodium, potassium, and other electrolytes. And the pathophysiology is going to basically stem from excess amounts of sodium and water retention, thus producing edema. Potassium and magnesium loss can be pro-arrhythmogenic. There can be reduced synthesis or uptake of myocardial norepinephrine. That comes from the remodeling that's associated with this compound. So lots of different pathophysiological processes that contribute to heart failure are attributed, at least in part, to what aldosterone does systemically. And so the way in which this works, here's the apical cell, here's the basal portion of the cell. And so aldosterone comes in, it binds to its mineralocorticoid receptor, which translocates from the plasma membrane to the nucleus. This produces a nuclear change and produces different genetic changes that essentially produce de novo synthesis of certain receptors and proteins and enzymes. The example here would be the sodium-potassium ATPase. And so drugs that are aldosterone antagonists, such as spironolactone, inhibit the binding of aldosterone to its receptor because it inhibits the receptor interaction. So spironolactone is a competitive inhibitor of aldosterone at the mineralocorticoid receptor. So the prototype, as we said before, is spironolactone, and it's going to compete with that aldosterone receptor. This is at the cell of the distal renal tubule, okay? And so now we're going to see an increase in sodium and water excretion, and that's going to also promote diuresis. And we're also going to see a conservation of potassium as well as protons. And so the rationale here is essentially we're going to counter the physiological effects of aldosterone, and that's going to have different therapeutic targets in terms of systolic heart failure. So we're going to reduce cardiac extracellular matrix remodeling. We're going to prevent fibrosis of the ventricular muscle. And these drugs are actually quite potent. They've been shown to reduce mortality by up to 30%. And although they are technically a diuretic, they're not a very potent diuretic. So there's not a lot of volume that's lost in terms of water with these. This is more of a mechanistic approach to a small amount of diuresis, but a robust conservation of potassium. There's really two drugs that you should be aware of that are aldosterone antagonists. One, as we said before, is spironolactone. This drug is metabolized by the liver to its active form, okay, which tells you that there's a slight delay in the onset of activity. And so this drug needs to be biologically activated. And so that process may take some time. And so there's a slight delay of activity. And so there could be several days before this newly administered dose will have any type of clinical impact. The clinical indications are listed there. More people are interested sometimes in some of the off-label mechanisms, and so it's been used in the past for acne in females, to control ascites. It's also been used post-MI in the context of heart failure, reduced ejection fraction function. Eplerenone is another aldosterone antagonist, and so here we're looking at liver metabolism. Instead of activating the drug like spironolactone, eplerenone has liver metabolism that deactivates or inactivates the drug. And so the clinical indications are pretty much the same: heart failure and post-MI, although it has been used off-label for the treatment of primary aldosteronism. So the physiologic outcomes to supplying aldosterone antagonists are varied. There's going to be a urinary effect, and basically the effect of urinary excretion is really going to depend on how high the baseline levels of endogenous aldosterone actually were before the therapy began. Structurally, there's some affinity towards the progesterone and the androgen receptors with spironolactone, and that explains some of the side effects we'll talk about in a few minutes. Eplerenone basically has less affinity for these receptors, and so it's associated with fewer side effects. Long-term use with spironolactone has been associated with oncogenesis and contains a boxed warning here in the US. And also, because of the potassium-sparing nature of this drug, potassium levels, of course, will increase, and so that's one thing to be aware of. And so the side effects, that potassium level increase may lead to hyperkalemia. Of course, remember it is a potassium-sparing. These are potassium-sparing diuretics. We can produce a metabolic acidosis. Okay, and then because of the affinity towards the progesterone and the androgen receptors, male patients in particular will sometimes complain of gynecomastia, and that is less encountered for eplerenone and more encountered with spironolactone, of course. And then renal problems, including renal stones and then acute renal failure, have been associated with some of these aldosterone antagonist drugs. And so that basically summarizes all of the pharmacology for treating heart failure. And so I just want to draw your attention to the next group of diagrams. And so here we're going to introduce the concept of combining the different stages of heart failure with which drugs are typically associated or prescribed during each stage. And so we'll leave off at this particular slide, and then this will pick up in the next presentation.